Hello, my name is Lisa Crowan. I'm an epidemiologist and director of the Autism Research Program at the Division of Research at Kaiser Permanente in Northern California. I am a white woman with short graying hair and I'm wearing a blue blouse.
Hello, I'm Maria Masolo, and I am an anthropologist and program manager at the Division of Research at Kaiser Permanente Division of Research. I am a Latina woman with short graying hair and I'm wearing an orange top.
This video will focus on the work we're doing in the Gender, Sexuality, and Reproductive Health node of the Autism Intervention Research Network on Physical Health, or AIRP. We hope that after watching this video, you'll have a deeper understanding and appreciation of the following three themes: issues regarding sexuality and gender in autism, issues regarding autonomy and agency in sexuality and gender identity among autistic people across the lifespan, and issues regarding consent and the prevention of sexual abuse and assault in the context of exploring intimacy. Now I'll provide a general overview of the AIRP and the Gender, Sexuality, and Reproductive Health node. A little background on the AIRP. AIRP is funded by HRSA, and it's an interdisciplinary multi-center research network to foster scientific collaboration with the goal of increasing the quality of life of autistic individuals. The purpose of the AIRP is to support innovative life course intervention research that promotes optimal health and well-being of autistic individuals across the lifespan. The National Coordinating Center is at UCLA, where the PI, Dr. Alice Kuo, works. There are four major components: a data repository and network management component, the Autistic Researcher Review Board, which consists of a group of autistic researchers at various stages of their careers. Their mission is to ensure that research conducted by the AIRP includes the voices of autistic individuals from across the lifespan, and that it ultimately aims to improve the health and well-being of autistic people as defined by them. There are also 15 collaborating research entities called CREs located across the country, and 6 research nodes with expertise in priority research areas for autistic individuals. The Gender, Sexuality, and Reproductive Health node is one of the 6 nodes. The network also supports a small grants program for early stage investigators and pilot and feasibility projects. It also coordinates and sponsors research days at the AUCD and CARES conferences, and it publishes a supplement in the journal Pediatrics each year, which highlights the research conducted by AIRP investigators and scholars funded by the AIRP. The Gender, Sexuality, and Reproductive Health node is co-led by myself and Dr. Masolo. Our node recognizes that sexuality and relationships are important contributors to life satisfaction, health, and well-being of all people. The node's goal is to improve sexual and reproductive health care and outcomes for autistic people across the lifespan, with a focus on autistic women and lesbian, gay, bisexual, transgender, queer, intersex, and asexual individuals. Based on existing, albeit limited, research on sexual and reproductive health services for autistic people, and input from autistic individuals, we've identified 4 major priority areas to focus on: sexuality education, sexual and reproductive health services, sexual victimization and abuse, and LGBTQIA+ health. In terms of sexuality education, we know that medical and support needs may affect puberty, sexuality development, autonomy, and personal identity. However, healthcare providers often do not discuss puberty or sexuality with autistic patients, and autistic adolescents are the least likely to receive school-based sexuality education. What's needed in this area is education and training for healthcare providers and school-based sexuality education curricula that is adapted for autistic youth. In terms of sexual and reproductive health services, we know that health services support self-determination and informed decision-making about sexual and reproductive experiences. We also know that there are large disparities in receipt of basic sexual and reproductive services. For example, research from our own group has shown that autistic individuals are half as likely to receive cervical cancer screenings as non-autistic individuals. Major gaps to fill in this area include improving access to gynecologic preventive health care and improving obstetric and pregnancy-related care. In terms of sexual victimization and abuse, we know that there are higher rates of sexual victimization among autistic children, adolescents, and adults, and that sexual abuse is associated with running away, sexual offending, and poor mental health. What's needed in this area is work on sexual violence prevention and research aimed at understanding the impact of sexual victimization and abuse on physical, mental, sexual, and reproductive health. And finally, in terms of LGBTQ health, We know that transgender and gender nonconformity is fairly common among autistic individuals, and that sexual and gender minorities have worse health and healthcare access than their cisgender heterosexual counterparts. What's needed in this area is a focus on understanding the impact of these intersectional identities on physical and mental health, and identifying and correcting unmet healthcare needs of LGBTQ autistic people. Our work is guided by the following 4 principles: using a participatory research approach to research, developing collaborations, developing the workforce, and identifying gaps in knowledge. Now, Dr. Masolo will now illustrate how we are applying these principles by describing some of the major activities the Gender, Sexuality, and Reproductive Health Node has been engaged in.
In terms of participatory approach, we adhere to the principles of community-based participatory research and to the call from the neurodiversity movement of nothing about us without us. With that in mind, early on in the grant, we created or convened an advisory group that now has 9 autistic individuals. The group is diverse in terms of gender and sexual identity, age, education, and experience. Our advisors bring to the node their lived experiences, but also their academic and advocacy expertise, and they're compensated for their work. Regarding collaborations, we are currently collaborating with an international team of experts who are drafting policy recommendations for the International Society for Autism Research, INSAR, on gender, sexuality, and well-being for autistic people. 2 members of our node's advisory group are part of the leading team working on this effort. And also through focus groups facilitated by another one of our advisors, we added the voices from the community on these issues. In terms of workforce development, we're currently mentoring 3 early career investigators and consulting with many others. The studies that are currently being done are, the first one is by Dr. Jennifer Ames, who is a staff scientist at the Division of Research at Kaiser Permanente Division of Research. And it's looking at OBGYN utilization of autistic people, people with other developmental disabilities, and people without autism or developmental disabilities. The next study by Dr. Laura Graham Holmes, who is an assistant professor at the School of Social Work at Hunter College at City University of New York, is looking among autistic individuals, patterns of service utilization, comparing autistic individuals who are sexual and gender minorities with autistic individuals who are not sexual and gender minorities. The third study is by Lauren Bashevsky, an ARRB scholar, who is a doctoral student at the School of Education at UCLA. That study is trying to understand the mental health care experiences of autistic LGBTQ+ young adults, ages 18 to 26 years old. All 3 of these studies include autistic collaborators in various aspects of the research process, from research design to data analysis and interpretation. To identify research gaps, we are conducting an extensive literature review, which we hope to publish later this year. This graph illustrates that gender, sexuality, and reproductive health issues were almost absent in the autism literature until 4 to 6 years ago. If we can see that until about 2016, there were minimal number of studies on these issues. And so I think that this graph also sums up that this is a new field that needs further exploration. This slide explains the years and illustrates really well when the very few articles that existed until the past 4 years.
And so now I think we're going to turn to a panel discussion and hear from advocates and Dr. Mazzullo and Dr. Krohn to share their experiences as we explore some additional questions. And so first, I think we'll all introduce ourselves. My name is Carrie Caulfield, and I work at the Boggs Center on Developmental Disabilities and the New Jersey LEND program. I'm the training director of the LEND program in New Jersey, and the Boggs Center and Rutgers University is one of the CREs for ARRB. I'm a white woman with dark hair, currently styled in a bun on top of my head. I'm wearing a white polka dot shirt, and I'm sitting in an office with a bookcase full of books behind me. And so now I'd like to invite our panelists to also introduce themselves.
Hello, everyone. My name is Marina K. Giwa Onaiwu. If you're viewing the screen, it says MGO. My pronouns are she, her, hers, and they, them, theirs. And I am a non-binary woman assigned female at birth. I am Black, I guess like between brown to dark skinned. And I have alopecia. Today I'm wearing Lily, which is my bob wig. And I am wearing a multicolored dress from my family heritage of West Africa. So it's got turquoise, maroon, white, and some other colors. I've got a couple of string devices on my arms and hands, and I'm sitting on the floor in my living room next to my kid's piano and some books and some other things behind me. I really appreciate being able to be here with you all. I am involved with the ARRB as part of the Autistic Researcher Review Board, and as well as one of the node members. And I'm just really happy to be here with amazing colleagues who really promote this work and care a lot about our community.
All right, good afternoon, everyone. This is Timotheus Gordon speaking, also known as TJ Gordon for short. He, his, him pronouns. And currently I am wearing headset, glasses, a black shirt that says Stephon Watts, Cessa Act, established 2021. I have locks, and I describe myself as a African-American cis male. And I am behind a background that's basically the logo of Chicagoland Disabled People of Color Coalition, also known as Chicagoland BPOC. And to describe that image, it's basically a red circle. Inside the red circle is a light blue background. At the bottom, you basically will see the skyline of Chicago. And above is the symbol for accessibility, which is a person in a wheelchair, but made out of many dots. I'm glad to be a part of this panel. It's a pleasure to be here. And as a autistic parent, as well as a researcher.
Thank you for being here. I'm so grateful that you're all here and that we're going to have such a rich conversation. So the first question that I will pose to the panel is this. So sexuality education is mandatory in most states in this country, and yet we have evidence that autistic youth are not receiving adequate sexuality education. So in your view, who should be involved in teaching autistic youth about gender and sexuality? And what should that teaching involve or be about, or sort of what should we be teaching autistic youth?
This is TJ speaking. To be perfectly blunt, it's really up to the parents, the caregivers, and the family members to teach autistic youth about gender and sexuality, since they are around the family and caregivers all the time. Yes, teachers can also teach about gender and sexuality at the appropriate grade levels, but the people who will reinforce it at home are more likely the people they're going to see the most all the time, which is family members. As far as what they can teach about gender and sexuality, well, the most important thing to teach, I strongly believe, is that gender and sexuality is more than just two things. It's more than two genders or type of sexuality. It's a whole spectrum. And it's better to teach our autistic youth about what is the spectrum of gender and sexuality and how they can navigate it in a way that is age appropriate, in a way that's consensual and informative, as opposed to what we have done in the past to autistic youth, where we either don't teach them about gender and sexuality at all, or we only teach them abstinence when it's a marriage or heterosexuality in that sense.
So I'm going to chime in, and I'm going to apologize in advance since we are talking about parenting and sexuality, and I'm a parent and I got some loud children upstairs, but it's getting quieter. And I'm loud too, so I can see where they get it from. But I really, really agree, this is Marineke, with what TJ was stating, that it's really important for the families to be on board. And I say that because that, you know, I'm going to get to the education piece in a moment, but the reason why I'm starting with the family is because, as TJ mentioned, that's your circle of influence. That's who you live with. That's who you're around a lot. And so if they're frightened to talk about sex because you're on the spectrum and they think you can't handle it or whatever, then that's coming from that type of an environment is going to create difficulty. If it's something that you're not supposed to talk about, you pick up on that. Or if it's something that people think you aren't ready for, you are going to learn, you're going to fill in those gaps with information some kind of way, either from your own mind, from what you see on TV, on the internet, hear from friends who are probably not very, well versed in these things. They're learning too, and their peers. And so I think that it isn't about teaching them any type of value per se. Not that people don't have their value system that they, raise their families with. Everyone has their own, personal code of ethics and what works in their home. But I think that letting people know about as TJ mentioned, the range of things, letting them know how things, because otherwise, if you only know about A and B, and you don't know about the other, 24 letters of the alphabet, then you think there's something wrong with you if you learn about or feel or think if those things don't fit. And you also don't understand the gray areas of life and when things don't go the way they're supposed to go. And so we'll talk about some of that a little later, but I want to talk about the sexual education piece because it's really interesting to me, as I actually was a former K-12 teacher, and thinking back at the education, the sex ed that I had in middle school and high school, and really what a joke it was, frankly. And I was, I was not, at the time identified as being autistic, so I wasn't in special education classrooms. So this is a typical public school, advanced classes, general ed, and yet parents could still opt out. That people would turn things into a joke. It was really learning more about structure and, kind of like really, the anatomy and so forth, and the technical part, as opposed to really learning about things that were practical when it came to sex. And there was a very, very heteronormative lens that was imposed on it. A great deal. And so, and it was clear that some teachers felt uncomfortable teaching it, but they had to, and others thought it was a big joke. And so I'm just thinking this is something that's so important. Like when you think about the high rate of sexual abuse that occurs in people with disabilities, period. But when you look at, intellectual and developmental disabilities and autism in general, when you look at the, higher rate, according to some studies, 3 times higher rate of unwanted sexual contact, 2.7 times higher rate of sexual coercion, 2.4 higher rate of sexual assault, with penetration, and there's so many other things. And then there's, research that shows that parents of teens, and we're talking about teens, okay? So this is puberty, right? Right. And even if your person is asexual, your body is still changing. That less than half of parents talk with their teens, their autistic teens, about how to decline unwanted sexual advances. Less than 40% of them talk to their youth in a few studies about how to I'm sorry, there's a word, I'm losing my words, about consent, about how to determine, enthusiastic consent or an assent from your partner. And less than a quarter of them talk to them about how to use condoms. And when you think about the sensory issues and all of these different things that have to do with prophylactics, that's a very important, thing for us to know. So I really feel like it should be something that's, I feel like in life, we're all supposed to be involved in things. We're all supposed to be involved in helping each other learn about culture and about ethics and about history and about gender and sexuality. And it shouldn't just look like, this binary narrative that may not be the reality for many autistic people, youth and adults.
Yes, this is TJ speaking to add to Marinake's spiel on teaching gender beyond male and female. As a autistic person myself who is cis male but also genderqueer as well, it's also important for people in general, especially teachers, caregivers, and family members, to even talk about the gray area of sexuality, where yes, you may look a particular gender or sex, but then your interests could be different than your assigned gender, and that is perfectly okay. For instance, it's perfectly okay for me to like My Little Pony or watch the Brat Dolls, either by myself or with my goddaughter. It doesn't make me less of a person. I just have to enjoy something that maybe my counterpart may not like, and that is okay. Same with, you know, if somebody who presents themselves as this female or female presenting, they may like cars, football, more than tea parties, and that is okay too.
I want to bring in, I think both Morenike and TJ are making really good points about the home and the parents being the environment in which children and adolescents should be talking about these things. And I want to play devil's advocate for a minute, if I may, because in the process of conducting research, I have interviewed many, many parents who say, we need help. I don't know how to talk to my kid about these things. These things are very complex. So how do we help those parents? What resources do we make available for parents and sometimes for teachers?
So I'm really glad that you mentioned that, because I think that, you know, we can say that the onus is on the family, but that doesn't mean they just, you know, intrinsically know, you know, how to talk about these things. And, you know, there's jokes about how it's difficult for all parents to have that conversation with their kids, you know, and so regardless of neurology. So it is true that they might not, you know. And so I think part of the problem that we have is, as you mentioned, there was minimal research about a lot of these topics for a long time. It was almost like the infantilization of autism was as if we never grow up, as if we don't have sex organs, as if we, you know, as if we don't live in this world with everyone else, you know. And yes, I understand there are things about us that are different. They absolutely are, and we should, you know, be cognizant of that. But at the same time, I think that some of it's individualized. So some of it is basically, you know, what is person A, person B is going to need something different. But I guess if we're just looking holistically, first thinking about the way that we process. So are you sharing things that are practical as opposed to just conceptual? Are you giving examples that are relatable to, you know, this person? If they are, you know, are you leaning on the way that they learn? So if they are a person who, you know, scripts or, you know, has a particular interest, are you using any of those kind of analogies to make it make sense? Are you showing them things online, diagrams, you know, or cool little videos or things like that? Are you allowing them to ask questions candidly, to read things, and, you know, and are you making sure you're doing so in a way that's neutral and not heavy-handed, like as if it's a chore, as if it's something that you dread, or or it's secretive or scary or bad, because even if you're sharing information, if you're being informative, but you're doing so in a way that is, you know, seems to be, it sends the message that this is a bad thing to talk about, then you know, it kind of codes everything in shame. And one example that I think about is when I was younger, and I discovered, you know, so my parents did talk to me about sexuality, but they did so really kind of more like out of it was kind of a special interest for me. So like really about like the reproductive system and, you know, how babies are made and all these kinds of stuff. And so it wasn't really about the sex part. And so I remember, you know, being a child, my parents worked long hours, you know, being a kid who was alone, you know, my siblings and I alone a lot, and watching some things on TV that probably shouldn't have been watching, and getting certain feelings, and feeling like I was some kind of a pervert or freak or sicko, because no one told me that watching people doing this or learning about this was going to make me do this, or if I touch myself this way, this is going to happen. I'm certainly not going to say that to a teacher, you know. And so it's like, I think that people really have to learn how to meet us where we are and communicate clearly and authentically with autistic people, and not freak out if we ask a question that's maybe not appropriate. Maybe say, let's talk about this somewhere else or at another time, but, you know, that's how we learn. And so I think that sometimes I'd say that people say, help us, we don't know what we're doing. And there are some resources out there that I know the Organization for Autism Research has created some things, and there's some curricula that's been developed, and some that's being reviewed or adapted for our community. But I feel like the conversation isn't held at all. And I feel like it's worse to not talk than to maybe bumble through it.
TJ, did you want to add anything to that?
Oh yes, this TJ speaking. And another thing to add is the great thing about the technology age is that we even have some advocates who are teaching parents and individuals with disabilities about gender and sexuality as well. And even those who invest in the disability community teach them about sexuality too, that is inclusive and more expansive. So whether it's elevators training, there's like many social media influencers that talk about sexuality, from relationships to exploring the LGBT plus spectrum, to even kink if the autistic youth is 18 plus. There's also, for those who stumble upon ethical porn, to show this is the ethical way to treat bodies. Of course, of age, plus 18, but still, there are, I believe if we also provide parents, caregivers, teachers, and even the youth themselves more options of letting autistic youth learn about their bodies, as well as providing with practical examples or play on how the youth learn, as Marina K mentioned before, then that's also a way that parents could get a better handle and more probably feel more comfortable talking to autistic youth about sexuality if they realize that there are some resources out there that can help them teach youth about gender and sexuality in a way that they can understand, regardless of what language or how plain language it is. And I also see in the chat, there's also the National Council of Independent Living have wonderful short videos about sex ed for people with disabilities. That's a great resource too.
I wanted to quickly, I know we probably have to move on to some additional topics, but quickly I just wanted to share that there is a colleague of ours, an amazing author, Corey Silverberg. And Corey, they were raised by a librarian and a sexual therapist. So it's like a very cool combination. But Corey has wonderful books that are written with, for various ages. And they're designed, there's, about teaching youth about sex, teaching them about their bodies. And I believe there's I think the third book in a series just came out, and they use neutral terms such as middle parts, as opposed to gendered terms for certain body parts. And you see a range of people with disabilities and different races and situations, and it's really great information. And so even though it wasn't necessarily designed with autism in mind, it was designed with there were focus groups with neurodivergent youth and adults of color, and it's a really great curriculum that I'd recommend anybody check out. And it's done in a fun, whimsical, colorful manner. It's not like manuals and textbooks and stale.
Thank you. I think the more resources that are developed and that we share, I mean, I think part of the hardship here is just knowing what's out there and knowing how to get the hands into get the resources into the hands of parents, of autistic youth, of teachers, of the people who need them. So I did want to move on to the next question that I think naturally stems from some of this conversation around education. And this is around issues of consent, abuse and assault, and in the context of exploring intimacy. So, what's the best way to bring this up with autistic adolescents and adults? How do we have these conversations? And are there resources that specifically speak to issues of consent?
So I'm going to just be honest with you all to say that in terms of things that can be utilized by the layperson, I know that there's some peer-reviewed articles and there's some things here and there, but outside of academia, I don't know how much there is that's specific to autistic adults and adolescents. I know there are some things here and there that you can find, but I have to be honest that just because something exists doesn't mean it's necessarily an appropriate tool to use. A lot of things that I see that are autism specific are really stuff that they took, slightly adapted from someone else, threw a puzzle piece on it, and like it's supposed to be relevant to us. And so I would say though, I'm hoping that others can share resources. I know this is something that's of importance, and I know it's something that people are working on. So I'm hoping there are some good resources out there. But I would say you've got to be kidding. The best way to bring this up is first to bring it up at all. A lot of times this is something that is not addressed. People don't know a lot about it. And so therefore you can't protect yourself from what you don't know, or you can't be cognizant, or you can't avoid not doing something you don't know. When you think about the fact that we have a social communication disability, we communicate differently. So things such as nonverbal communication, or perspective taking, and things being implied as opposed to being stated clearly. A lot of these things make things challenging and complicated for us.
I agree with Marina K that even though there are resources available that address those topics, how plain language it is to those who may not understand academia, I'm not sure either. And even how to bring this up to autistic adolescents and adults, you know, it's hard to even talk about just consent, abuse, and assault in general because most of it is painful, especially if you are a survivor of abuse and assault or know of somebody in those situations. With that being said, what would be the best way to bring this up with the autistic adolescent and adult? If you, as a parent or a caregiver, no, it's okay. Medicaid, it's all good. It's unacceptable. But I think the best way to bring this up to autistic adolescents and adults is if you are a parent, caregiver, family member, teacher, or whatever, a mentor who went through similar things, it's best to share your story and also provide context of what consent looked like and how to navigate the resources in case they don't respect your wishes. And honestly, that's the best way to bring it up I can think of. But as far as bringing it up in general, again, it's Marinike maybe may have a better idea, or anybody else on here may have a better idea, but I personally don't know simply because, well, consent, not as much. I mean, there's the tea example that people will use. I like tea, but some people may not like tea.
I love that tea consent video. I love it. I use it in my classroom.
Yes, but basically for those who are not familiar with the tea example, there's a YouTube video where consent can be learned by example, the tea party. Some people like tea, that is okay. Some people don't want tea, and we should respect people who don't want tea. Some people may like certain type of teas. Some people like it hot or cold. It's a similar thing with consent where it's all about asking and respecting the person's wishes. Even if the person is unsure, you still respect their wishes anyway. It's just, again, from a parent perspective, especially as a father and godfather, at least for me, it's hard to really bring this up unless the time has come to bring it up, or it could be difficult because you don't want to scare off people, if that makes sense.
It makes a lot of sense. And I'm sorry.
No, go ahead, Marinike, because you were in the middle of something very interesting before. Why don't you finish that? And then I had a question for both you and TJ.
Yes, and I hope I get this right. So one thing I was going to say that I loved about the tea video and the tea example is it talks about the fact that just because you like tea all the time doesn't mean you want tea right now. You can't go to somebody's house in the middle of the night and be like, and start pouring tea down your throat thinking, you drank this tea every day last week? They may not want it right now. Or someone could be literally in the middle of drinking a cup of tea and decide, I don't want this tea anymore, I'm done. And then you shouldn't force them to drink the tea. And you shouldn't be pressuring somebody like, well, if they're like, I don't know, no, you really want this tea. Come on, just a little bit of tea. So like it's comical, but it shows you a lot of things. It helps you to really kind of bridge the, some of those gaps, because I think about, Netflix and chill didn't mean, I thought that's what it meant, Netflix and chill, go watch some movies, chill. I didn't know, it's supposed to be all this. Like, to me, being direct, do you want to have sex? Would be a better thing to say. You might get a yes, you might get a no, but all this hinting around was really confusing. And I think that I've realized through in life, I found myself in situations where through that I was just being myself, but people misread the cues and thought something that, that I was sending signs that I wasn't. And I think that this isn't something that is easy to talk about, but the reason why it needs to be talked about is because we often don't realize sometimes these things can be so subtle: abuse, assault, consent. And when you're dealing with people who, when you think about a lot of the treatments and interventions that are available for autism, they're taught to teach you what you think and feel is weird, and you should deny what you want and do what everyone else does or wants because they are more normal. So, well, this sounds loud to you, it's not loud to everybody else. Or, you don't feel like saying hello and shaking hands and making eye contact, but that's the polite thing to do. People don't realize they're thinking, we're just trying to make them, kind of fit in or make things easier for them. But that's going to translate into so many areas of one's life, including sex. Are you going to feel like you really have a right to turn this person down? They're really horny and maybe you, whatever, or, or you're a bad person, or maybe you want somebody that's going to date you and is going to listen to you info dump or whatever, or maybe you're asexual and now you feel like a freak because everybody around you is having sex and you're not into that, there's just so many things. And then the sensory aspect. Are you going to be able to properly negotiate certain prophylactics if they are bothersome to you in terms of your sensory needs? And so I feel that there's really, it's never an easy thing to talk about, but it's so much easier. You know, there's a saying that says an ounce of prevention is worth a pound of cure. And I know very few autistic adults, almost none, who have not been, you know, pressured or assaulted or intimidated, harassed in some way sexually by other people who felt, you know, and that's not right. It isn't right, but it happens to us. And a lot happens at work. It happens in social situations. It happens in schools, and no one's asking us about this. No one's doing a domestic violence or intimate partner violence screening for us. No one's asking us these questions, and so this becomes normal. Only it's not.
That last point you brought up, Marineke, is what I wanted to ask you and TJ about is what do you think the role of healthcare providers is in this whole topic of, you know, exploring consent, teaching about assault, matching the intervention or the contraception to the you know, the needs and the whatever of the patients, and then also about teaching about sexuality education.
That's a great question, Lisa. This is TJ speaking. This is a great question. Because part of it requires clinicians and other stakeholders to accept the fact that disability is a part of that conversation. Those things happen to people with disabilities, or some people with disabilities may even be perpetrators, either doing it on purpose, or they may not even know that this is not consent. This is not how you interact. They don't know. So part of it is how much the clinicians and stakeholders either know or want to know the intersection of consent, abuse, assault, and the disability community. I think it should be more people studying about those intersections, as well as more clinicians making it a practice to include disability when it comes to providing resources on consent and how to handle instances of abuse or assault, whether it's prevention or, for lack of better words, and when and after it happens, or the resources to cope and navigate through those instances.
I like what TJ said, and just to add to that, I think there is a huge role actually for clinicians in this, and maybe more so than in non-autistic youth, because I think that, and you know, and young adults, because I think that our interactions, you know, and maybe even frequency of our medical visits, you know, and the types of, you know, I guess multidisciplinary things that are being addressed that might not be addressed in a, you know, in maybe in a standard, say, pediatrician or whatever visit. These type of things are kind of part of the care, and so I think there's room to kind of to address these topics. You know, I think about like when they talk about development, so when your child's getting to a certain age and they're asking these different questions, developmental screenings, or when you're starting talking to them about this or that, you know, like all of the different suggestions at certain ages, a lot of times people just kind of bypass certain things when the youth is, you know, has an intellectual or developmental disability. There was a really large study in 2014 that found that 84% of U.S. you know, adolescents who were considered, you know, perceived by the provider to be like moderately or severely impacted by their disability received no sexual education at all. They were allowed to, the parents were allowed to opt out of it, and it was not talked about. And you know, and so sometimes these things aren't addressed until somebody got a baby on the way, you know, or whatever, or so somebody's been harmed, or so somebody is pleasuring themselves in public, and because no one has told you can go do that privately in your room or the restroom, or, you know. So I think that it's really important to I'm sorry, I just lost my train of thought so quickly, and I cannot believe this.
It's okay. It's autistic, baby. It's all good.
Yeah. Gosh, I feel like it was important though what I was going to say, but unfortunately I can't recall it. And so I'm the right role of providers. Yes. Okay. So one thing that is really, and I know this isn't going to work in every time. I know, first of all, I know providers are busy. Clinicians are kind of juggling a whole lot of stuff, trying to do a lot in a little bit of time, you know, so I think really everyone should kind of give them more grace because they're really trying, you know, but so one thing I think to advocate for more comprehensive education for this, you know, the youth, the up and coming, you know, early career and, you know, graduate students and undergraduate students, whether it's, you know, nursing or allied health or research or whatever, medicine, there isn't enough informed information that comes from the people with lived experience. So advocate for those changes. I'd say another thing that could be done is just create these conversations. Like, there's models, like when you look at the medical home model, or when you look at like some of the comprehensive care models that you see with certain chronic illnesses, or with like adoption care, for example. Those are things that you have people who are addressing the psychosocial, the medical, and so on. And those are conversations that are brought up. They start introducing little things here and there as the children get older, asking different questions, and to the child as well as to the parent. And, even get to a point where they'll say, Mom, Dad, if the kid is okay, could you go in the hallway for a few minutes so we can ask the child some questions? And you're kind of thinking like, huh? But there might be certain things that the child may not be comfortable saying in front of you, or questions they might want to ask about the way their body is changing. And so I think that if you acknowledge that there might, and the child may not want to talk about it, and that's fine. But I think if you acknowledge that there's a possibility, that something needs to be talked about, you ask what they know, you share any resources that you might have, make yourselves approachable. On your website even, like, it shouldn't just be, oh, people can come on and make an online appointment. What's in your resources section? Have you looked at it in the last 5 years, other than when you put some COVID stuff on it? Like what is there? Give us, throw as much as you can at the wall, and some things won't be necessary, or we'll filter away, but some things will be really helpful. I think you all don't realize how much of a trusted figure you all are in a world where a lot of people don't really understand or get us. And so you could be the reason that you could be the one that introduces or shares or explains something to us in a way that helps us to really get it.
I think that you're making a really good point, Marinike.
Sorry.
And sorry, TJ, go ahead.
I was going to quickly add to Marinike's point on the clinicians being more knowledgeable about the disability community, and even those in the early careers or students. I mean, another way to look at it is just come up and talk to us. Hang out with us, learn about us. Just like you would with anybody else, you try to get a better understanding of not only personally, but also in your field as well. I mean, come to our advocacy events, come hang out with us at socials, come see how our family life is, just get to know the disability community and be active and supportive about it. It's easier said than done. No, go ahead.
It's like, and please don't treat us like big kids. Like a lot of people, please don't have we may, what we like or don't like, I think that things shouldn't be really, just like, things shouldn't be gendered. I think age as well. Like if I love Steven Universe and I want to talk about it all day long, it shouldn't matter that I'm not 15 or 12 or whatever, so I think that, but I think that sometimes people talk to our parents instead of us. And it's important to talk to parents. TJ and I are both parents. We love our kids. We'd love to give insight about that, but everyone has their own thoughts, their own feelings, their own body, their own story. And so I think that particularly when people present, if people, maybe are minimally or non-speaking or seem to have cognitive disabilities, people seem to act like that same testosterone or progesterone or estrogen or whatever is not running through their, through their veins and arteries and, vessels and everywhere else in the body. And it is. And so even if it's not even against sexual, even if it's just about understanding who you are, how you're changing, I think about how I'm grateful that my mother talked about some of these things with me, because my sensory issues, I can't stand certain smells and things like that. So I didn't have a situation where, I started having body odor and I didn't know it. My mother let me know about this stuff long before it ever showed up. So I didn't have to, because that could have caused meltdowns for me if I'm, if things are happening and I can't control it. And so I think that, I think there's a lot of things that are addressed or brought up in the doctor's offices. Like sometimes it's like you all are talking about certain, like you might be talking about the vaccine for cervical, cancer that you might be offering at a certain age, or you might start asking questions about, like safety. So there's certain things that are kind of already part of your role that you can kind of like, I guess gently ease in and do so in a way that's neutral. Like, please, I can't tell you how many friends I have who've been made to feel shamed or horrible because they're 24, they're 29, and they're still a virgin. Everybody doesn't want to have sex, or maybe they don't want to have it right now, and so people are looking at you like you're a weirdo, like because your developmental timeline is not like that of others. There's no rush to this stuff. It's not going away, and so I guess to, presume competence, essentially. So whether the person's sex life is not what you expected, because some people might be very promiscuous. That's their way of trying to, fill some type of sensory, void, or be liked, or it's what they've been conditioned, or they're being, abused. I mean, it could be a variety of things. We don't know, and then some people may. It's a huge spectrum, and it just needs to be treated as such. And so, thinking about the the provider who asked me a question about how many sex partners I'd had, and the eyebrows got big. I'm thinking, well, why'd you ask? You know what I mean? Like, if you can't handle the number I'm going to say, like, the next visit, the number might be 0. You know what I mean? But,
I'm TJ Gordon, and thank you for bringing that up, Marinike. Thank you, because the another thing that clinicians could learn more about is that autistic people can choose not to have sex, can also choose to have sex in many different ways or different amounts, or even interact with people in different amounts. I mean, there's many people who are polyamorous or non-monogamous, and that is okay. Instead, there have been instances, even for me as an adult, where I got shamed to get an STI testing to ensure that I'm sexually healthy and practicing safe sex with people I interact with. But the minute they not only are surprised that I'm in a relationship or I'm into polyamory, but also the fact that I asked for a test, that's got to stop also.
Yes, TJ, thank you, because oftentimes people have to ask because it isn't offered to us. I think about how often, like, why is it that, you know, some of these things should be a part of general health overall, and they aren't. And so people are, you know, sometimes people don't even know what, there's just so much that we, you know, like, I think if we just took a different type of approach, you know, one that was just, you know, that was more about informing and guiding people and not so prescriptive in certain ways. Like, I think that it shouldn't be, sometimes parents, you know, the clinician is talking to them only about sex to tell them, well, you really need to get guardianship of your kid, because, you know, there's certainly, you know, when they get in a group home, you want to make sure they don't do this or they don't do that, or you want to make sure that, you know, so it's really about control, about, you know, like controlling their bodies because you don't know or you don't think this, you know, how many people who are forced to, you know, have an IUD or what have you that they don't want because they're perceived as not being capable of caring for a child, or they're not allowed, they're in a you know, living situation, maybe partially recommended by the people that the parents trusted, professionals, educators, clinicians, that doesn't allow you to have a real life. Like, you're a 20-something-year-old and maybe you want to date and you want to have a girl in your room or whatever, a guy or a person in your room, but that's not allowed at this place that you live in. You know, like, the rules never stop sometimes for us, you know, and that's just not the way life should be. People should have, you know, people should have variety. We already have enough barriers as it is.
I think you're both really underscoring the huge need for provider, you know, health provider education about disability. And, you know, you're both bringing up all of these assumptions that you've been faced with, you know, when you've gone to the doctor or had a checkup or whatever, and you know, assumptions about your behavior or what you're doing or what you're not doing or what you should be doing that seem so, you know, unfair, frankly, and probably different assumptions they're making about you than some other patient who, you know, they see. So I think that this issue of provider education is so critically needed, and all different kinds of providers, you know, and school educators, healthcare providers, allied professionals, the whole gamut.
Absolutely.
I also want to add quickly that we talked a lot, and you made really good cases for consent, right? And I think that consent, we're talking consent, obviously, in the context of sexuality and gender and what to do. But I think that consent starts perhaps earlier. And it is something that parents and healthcare providers perhaps should model, right? Because, Morenica, you said, oftentimes I take my kids to the doctor, but the doctor talks to me, as opposed to talking to the child, right? Add to that, if you have a person with intellectual disability or different processing abilities, the doctor doesn't talk to them at all, right? And the parent responds. So I think that we need to bring back consenting. I cannot tell you, I can give you anecdote after anecdote of us when we were research assistants, or we're in the process of a parent coming to participate in a study, right? And we're so grateful for them with a child. And we explain to the child that they don't need to do anything they don't want to do. They don't need to answer any questions. And then the time comes to say, okay, give us a saliva donation. And the kid said, I don't want to do it. And the parent said, oh, come on, you can do it. This is, you know, and we're there saying, okay, who do we believe? You know, the child is saying no, the mom is saying we need to contribute to science, or the dad. So consent, right?
Yes, that is so powerful. And that's where it starts. Like, these are people who love us. These aren't monsters. These are our parents who advocate for us every day, take care of us, who, you know, they care, but they can sometimes cross those lines of consent too. You shouldn't have to give Aunt Mary a hug because, you know, just because she likes it. Maybe it makes you uncomfortable. You shouldn't have to give this saliva or this blood, you know, unless obviously there's a, you know, for something that's elective, like a research study, when you know, as opposed to like an emergency situation for one. People should be able to say no. And parents, no one's perfect. Parents don't know everything. They don't like everything. There's not going to be, it's just more about like allowing someone to have a voice, even if your voices dissent from one another. And that's the part that I feel like you're saying is right. If your child says no, even though you did a social story and you drove 40 minutes here and all this kind of stuff, and you thought they were okay with it, and now they're saying no and you're really annoyed, you might roll your eyes a whole bunch on your way home, but don't force them to do it, because that forcing them to give the saliva today is them being pressured on a date to have sex with somebody they don't want to in 4 or 5 years or 10 years.
Precisely. And the other thing, Morenike, is once those children turn 18, parents and healthcare providers assume the parent, in many cases, will have guardianship, as opposed to, assisted decision-making, right? In which they can still make their own decisions with help. Right, so I think that it should start early on, and I don't have the answer of how we train parents and healthcare providers, maybe medical school students, to say, make sure that you get consent from your patients.
And
Absolutely.
that you give opportunities for consent, and gradually build opportunities to practice and develop skills over time. Absolutely. Absolutely. So TJ, I don't mean to interrupt, but I know that we are over time. And so I just want to invite all of our panelists, if there's anything that we haven't touched on or that you'd still want to share to your audience of LEND trainees and fellows, I invite you to go ahead and sort of share closing thoughts or that final thing you'd like to say as part of this panel.
If I may, this is TJ speaking. I think the final thing to note for those who are watching this panel, this presentation, we spent a lot of time talking about exploring sexuality, exploring relationships, exploring gender, which all of that is on a wide spectrum. I also encourage you all to include more people with disabilities when it comes to helping them navigate parenting and parenting resources. For just take Morenike and I as an example, we both are parents. Therefore, we need parenting resources too. Please understand what we go through, so that we don't have to face the possibility of losing our child because the courts or providers deem us, incapable, or even our family members, or even the person who helped create the child said we are incapable, even though we are more capable. We are capable, it's just that we need more resources and accommodations, or maybe a different parenting style, but still treat us as human in regards to being disabled parents. In the same way you treat people from various sexualities, genders, and such with equity and respect. Do the same for disabled parents.
I agree. Just resources across the lifespan are important, and that can be utilized by as wide an amount of people as possible. I think a lot of assumptions are made. Don't assume because someone may appear, from your perspective, to have very, very high support needs, that they have no sexual desires or they have no aspirations for a career. Don't assume because a person appears to pass or has a particular IQ that they may not still need support in other areas. And don't assume that all parents are are neurotypical when a lot are not. They even non-autistic parents, a lot of them are neurodivergent in their own way. Human beings in general, we could all learn from having a wide variety of tools and methods and information that we can choose to use. And so I just feel like if we can don't forget, we don't turn 18 and disappear into the oblivion. We still exist. And and I think it's important, really important, for people to don't go by what you see. Your assumptions are just that, an assumption. And so you don't know what that person needs. So don't, as easy as it is to kind of, generalize and put things in categories, and it might seem to be efficient, it can also be extremely harmful. And so really just having some humility, asking questions, trying to learn more, and just, being open and to changing the way that you think and you operate with with others. It could really be life-changing for us.
Can I just make a final statement, which is this is really a plea for some of you who are interested in research to take on this field. There's so many unanswered questions. There's so much work to be done. There's so many gaps, and I think, as you've heard from all of us, a lot of really thorny issues that need to be overcome. And so it's a wide open field, and we'd love to encourage any of you, any and all of you, to look into this if you're interested in doing research in this area.
I think that my parting words would be also to encourage people, as I said earlier, to start modeling consent and the limits of what I want to do, what I don't want to do, what feels good and what doesn't feel good at a very young age. And this goes both for parents and healthcare providers and supporters. And thank you all. This was the most wonderful conversation.
Yeah, really great.
I want to echo that. Thank you, all of you. This was so enlightening. I am sure the trainees are hearing about so many topics that they're curious about, they have questions about, they could use resources and information about. And so I think this is the beginning. And I'm sure that they will continue